Hi, I'm Dr. Jody Polaha, and I'm a clinical psychologist and associate professor in the Division of Primary Care Research within the Department of Family Medicine at East Tennessee State University. To introduce this module, I thought I would tell you how I got started as a primary care researcher. My first experience with integrated care was as a postdoc at the University of Nebraska Medical Center. I had been working with an interprofessional team including nursing, genetics, and psychology, which made regular trips to see patients in rural parts of the state. Through this work, I made the connections to start an integrated behavioral health service in a pediatric clinic in Hastings, Nebraska, about 150 miles from Omaha, where I was based. At the time, my primary motivation was to get best practices in pediatric psychology out to rural areas where there was a significant shortage of mental health providers. I would drive out and spend 2 days there seeing as many patients as I could, sometimes giving community lectures in the evening. Of course, the longer I stayed on, the more advantages I could see to integrated care, the ease of care coordination being the main one. But eventually I realized that one of the biggest advantages was that I could bring my skills to bear on systems change and impact the lives of many children, rather than the few that I could see face to face. ADHD is one of the top problems in pediatric primary care, and I was aware that the practice was not using an evidence-based approach to assessment. I also noticed that they frequently sought my advice for this presenting problem. This graph shows the non-evidence-based measures the practice was using, but it also shows that in an archival review of patients from one calendar year, they only collected those measures in about 30% of cases. It was not a very well implemented system. They were open to me coming in and revising their ADHD assessment strategy. Over a period of a few months, I worked with office staff on a procedure for handing out, collecting, and scoring evidence-based rating scales for parents and teachers. Over a few brown bag lunches, I described the protocol to office staff and providers, and I developed an easy summary sheet so that providers could easily interpret and use the measures. After the new system was in place for a few years, we went back and evaluated how it was going. This chart shows that the evidence-based measures were being collected for over 85% of the patients for the year after implementation, as well as 3 years later. I was impressed that I could extend my influence in this way, not just seeing patients one at a time, but impacting the care of many patients by effective program implementation. Plus, I could see the providers were much more comfortable with addressing ADHD in their daily work. Even better, by publishing the study, I was able to impact even more lives through dissemination. I loved this kind of work, but at the time it had no home in the research methods of psychology. Today it does. The field of dissemination and implementation science offers psychologists an opportunity to research not just the effectiveness of our interventions, but also their impact. In 2013, I was able to complete an NIH-sponsored fellowship to study this area. I hope you enjoy learning about it as much as I enjoyed doing it.